Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
Many of us, or our friends, or our family have heard the words, "You have cancer." It's always a shock, and then you think, oh, now what? Wouldn't it be nice if someone took your hand and showed you where to go, what to do, who to talk to, and most importantly, what questions to ask? Scientific advances are revolutionizing the approach to cancer treatment, leading to a very specialized medical care for each individual. And we have experts talking about personal cancer care and, more importantly, navigation. What do you do once you hear those words? Where do you go, and how do you figure out what to do? This evening's program is underwritten by Tenet, the Hospitals of Providence, and a big thank you to the El Paso County Medical Society and all the doctors who have been bringing the show to you for over 26 years. I'm Catherine Berg, and you're tuned into the El Paso Physician. Thanks for joining us. Today, we're going to be talking about cancer navigation in the El Paso region. What does that mean? Navigating for patients is a very difficult thing to do. Again, if you've been diagnosed with cancer, you kind of don't hear anything else for a while when the doctor talks to you. And so you go back home and then you start assessing, what is it that I do? So with us this evening, we have Dr. Raul Loya, who is a radiologist, and then we have Dr. Robert Prieto, who is an oncologist, and he is the class clown of the group. He giggles, but if you were here about 20 minutes ago, you'd understand why. And throughout the show, I hope we'll have a little bit of fun with this. And then we have Claudia Sanchez, who is a nurse who is the patient navigator, and we're going to learn all kinds of stuff from you. If you could, Dr. Loya, explain to us what it is that you do all day, every day. There's a radiation oncologist, there's a radiologist, there are differences in these words, but a lot of people get them mixed up. It's kind of like if you have an optometrist and you have an ophthalmologist. It's like, well, they're kind of the same thing, right? So if you can explain what you do, and that way it's kind of easier for the audience to kind of wrap their hands about what we're going to be talking about this evening.
Of course, yes. So as a radiologist, throughout my shift, I interpret every study that comes in the hospital. That doesn't necessarily mean every study is an oncology study. I interpret studies from the ER. I interpret studies that are follow-up oncology studies, cancer studies. I interpret all sorts of things. But my specialty within radiology, for example, is body radiology. And so I try to focus on studies that are targeted towards abdomen and pelvis. And within those, we have a lot of oncology follow-ups. And it's very important for me to give the information to referring providers such as Dr. Prieto about how the cancer may be progressing in a patient or how cancer is responding to treatment. So we take that very seriously. We always compare studies, and we try to give the best information possible to our oncologists.
I love that you said we compare studies. I always think that's so important. And so really when you're talking about the abdomen and pelvis, this is organs. You specialize in organs and trying to read the different cancers or growths on organs. So I appreciate your explanation on that. Dr. Prieto, when you're talking about you're an oncologist, that's also a loaded word, right? You deal with so many things, and some people like to call the discipline hematology, oncology, etc. But when you're looking at your specialty as an oncologist, do you have something that you kind of bear down on, or is it all oncology?
So there's different fields in oncology. Some oncologists specialize in one or two specialty fields, and they become experts at that. Usually in big cancer centers, say like MD Anderson or UT Southwestern, they have oncologists that specialize, say, in breast care or lung cancer or urology, oncology. Here in El Paso, what we have primarily are general medical oncologists, community-based medical oncologists. Most of us are also trained in hematology because there's a good overlap in both fields, both from hematology to oncology. And so
Explain what hematology is.
hematology is a study of blood. And the overlap between hematology and oncology is the fact that there's a good amount of hematology whereby cancer arises. Leukemias, lymphomas, those are all considered hematology-based type of cancers. We call them fluid cancers. And then we have the other side, which is the medical oncology, and it's the solid organ disease process of cancer. There we find lung cancers, pancreatic cancers, breast cancers, cancers of the head and neck region, brain tumors, brain cancers, kidney cancers, liver cancers. So basically anything that is a solid organ that develops cancer.
Okay.
Okay.
And I asked the question about hematology because I feel like there is, and I know we're not going to focus on that today, but there are so many more tests now that do involve a blood test to see what it is that we may or may not have. Very beginning stages. There's also genetic testing, et cetera. I know we're not going to focus on it, but that's always a question that people have. So we'll talk a little bit about that throughout
Very
the
good.
day.
Excellent.
Okay,
Yes.
excellent. Claudia, this is your show because this is all about patient navigation. When you started this specialty, what is it exactly that you do? And that's the question. What do you do all day, every day, right? But really your relationship with patients, and I think also your relationship with the family members too, right? The patients have questions and the family members sometimes are the ones that ask the other questions because the patients sometimes are still in shock. So if you kind of explain what it is that your role is.
I'm glad you brought up the family in this because when someone is diagnosed with cancer, it affects the entire family. And so my job is to make sure that the patient understands what they have, okay? And also for the family to understand what is it what's going to happen from here on out, okay? They have decisions to make, okay? And we're there to provide those kinds of answers to them. We're here to explain to them treatment options so that they can make an informed decision as to what it is that they're going to do. There's a lot of different treatment options available for some cancers, not all of them. Some are very straightforward, they just need one thing. But it involves other things that happen. There's symptoms or side effects that occur with treatments. And so we're here to provide education about that. And how are we going to manage those symptoms? How are we going to manage the side effects?
Right.
When do we have to call the doctor? When do we go to the emergency room? Things that, and not just the physical. We're looking at the social aspects. So we're trying to break down barriers. So there's individuals that maybe they don't need anything at all from us. They're good. Sometimes, we explain things to them and they're like, okay, and then that's it. They don't really need anything from us. We call them, how are you doing? And everything's fine. But then there are some other individuals that they don't know how to make a decision because they don't understand what is being offered to them. Okay, they don't understand the process, or sometimes they delay things because they don't have transportation to their treatment. They don't maybe they don't get scheduled for something, and they just kind of like, well, I didn't get that scheduled, so or they schedule it way far out, and it can be done. It needs to be done immediately. Right. And so, as a navigator, that's our job to let them know, like, no, we can do this sooner. Let me get help for you. Let me, break those barriers so that you can get your treatment in a timely manner, so that you'll have a better outcome at the end of the day.
That makes all the sense in the world. It can be overwhelming. It is overwhelming. Not can be. It really is overwhelming. And then there's that whole idea that analysis, what is it, paralysis by analysis? It's like there's so many options sometimes that you don't know where to go, and you think, well, tomorrow I'll make that decision, then tomorrow turns into next week, et cetera, et cetera.
You know,
Yes.
one thing that Claudia said that is so important is the informed decision, informed decision and informed decision making that many people, because of the word cancer, just get paralyzed, as you say, and then they're not sure the information that they're hearing, how much of that they have to act on.
Right.
And many patients end up basically following a course of plan simply because the doctor said so, without understanding ramifications, without questioning many times. So informed decision making is terribly important. And I think that's one of the things where a navigator can really come in to handhold that patient, that family, and explain that there are options. I mean, not too long ago, last week actually, I had a patient in my clinic with a pancreatic cancer, and I was planning all sorts of different studies to get him staged, planning referrals to surgeons, radiation, and the patient basically stops me on track and tells me, I don't want any treatment.
Oh my goodness.
And I said, this is still curable disease. He says, I don't want any treatment. He says, my medical problems, where I am in life, he says, I just don't want any of that. So I had to go through a pretty lengthy explanation of what his choice was at that point, or what his desire was. His family was present, and so we had a very, very lengthy conversation about the pros and cons of his choice, and then the pros and cons of following an aggressive treatment course, what he was giving up by not doing what I was recommending.
Was age a factor in that situation?
So he was younger actually. Okay, so he was not like an older person, still
That's
solid.
immediately where my head goes. If you're, 70, 80, 90, it's like,
That's right.
okay.
And part of the reason that I felt so apprehensive and just sitting and saying, okay, well, you don't want anything, let's let you go, was the fact that his age was still very reasonable, where he could proceed with treatments and tolerate them, where there was still projection of significant lifespan ahead, where he would derive benefits from the therapies. At the end of the day, at the end of the conversation, basically, he still said, no, I hear you, I understand you. He says, and I still am holding to what I told you. And I said, I think you understood the conversation well enough. I think I feel comfortable that you understand the consequences of your decision, and then the different choices that I've discussed with you. And so I have to respect your choice at this point, because you have autonomy, and I have to respect that autonomy.
Right.
Informed decision making, and that's what I basically ended up documenting in my note. After a lengthy discussion, the patient, through informed decision making, decided to forego any aggressive treatments. Very sad from my perspective as a doctor, because you want to intervene, have a very positive effect in a person's life, hopefully something that results in a cure. And in this particular case, you have to allow that person to exercise their free choice.
Right. Yeah, your whole goal is to help people and, for the lack of a better word, fix them, cure them.
Absolutely,
If at all
yeah.
possible.
Yeah, as doctors.
I can imagine.
As doctors, we'd like to do that, okay?
Yes.
Surgeons especially like to do that.
Yeah, Dr. Lori's like, yes. I have a question that kind of is going to lead into almost everything else that we're talking about. And I know we sort of try to figure out how to ask this question before the program started, but the status of oncology services in El Paso now. And I would love for the audience to know where we are now compared to a decade ago, 2 decades ago, years ago, and I'm going to say 2 decades ago, was depending on the cancer. And Claudia, you had a perfect way of describing it. Some cancers are, this is what you have, this is what we need to do, and boom. A lot of them are very clear. A lot of them are not. And so people would leave town to find different options of treatment. So, and I'm going to throw that to anyone who wants to take that on. Dr. Lori, I think that you immediately chimed in earlier, but the services that we have in El Paso, when I say services, the treatment options, the doctors, the different facilities that we have, where are we now in 2023 when it comes to that?
Yeah, no, at Providence, we have 2 women centers that focus on diagnosing women diseases, in particular breast cancer. And so we have the most up-to-date technology. We provide 3D breast imaging. And at the same time, if we localize something that is suspicious to us, for example, calcifications.
Oh, that's me.
Yes.
Totally, not kidding. Went to
Both.
your clinic and that's what they found out and boom, boom, boom.
So we provided 3D guided imaging with a biopsy. So that's very
Stereotactic biopsy.
Stereotactic biopsy
Yeah.
with 3D tomosynthesis. That's
Goodness
correct.
gracious, yeah.
And even in our Joe Battle facility, we have it so that we receive and we view the specimen right away,
Real time.
real time.
Really, while you're there.
So before,
Okay, so I had that done over a decade ago.
right,
So that's nice to know.
perhaps we had to take 12 course.
Right.
Now, say the patient is at higher risk of bleeding, and in our first 2 course, we see that we have what we needed, then we can stop there.
Nice. Okay. And so that's something that stereotactic biopsies is something, if you can explain what that is too, because you're a radiologist, you're basically in a mammogram,
Yes.
real time as the biopsy is being done, because that's how you can see where you need to go to. Explain that to the audience, because I think people don't understand that. They think, okay, how is a biopsy guided? How do you know exactly where to go? And I think
very
it's
important.
fascinating when people don't know.
No, very important. You bring up a great point, and I'll take a step back.
Okay.
So in mammograms, a lot of what we're trying to look for is very, very early stages of cancer. That's why we do the screening. And we take a look at calcifications. Some of the calcifications have a benign morphology, but some have a suspicious morphology. And so we do the mammogram, and then the calcifications, we would not be able to see them on ultrasound.
Bingo.
So we have to do a biopsy that in which we are able to see what we're targeting. And that's where the stereotactic guided biopsy, a mammogram guided biopsy comes in. We're able to see the calcifications and target them with our stereotactic guidance. So we have a mammogram guided biopsy in which we're taking out a portion of the calcifications.
Okay. So let's switch body parts now. So let's talk about prostate
Of course.
biopsies, because that's a smaller group. I mean, you're looking at a prostate the size of a walnut, if that's still appropriate. So when you're doing biopsies of a prostate, because again, it's a small organ, and then biopsies in general, how is that done?
Yeah, so that also we have advanced imaging here in El Paso as well. So it used to be that the urologist would do a lot of the biopsies, and some would be multiple biopsies in every part of the prostate gland. Now we have, specifically at Sierra Providence, we have an MRI, a 3T MRI, in which we can take a look at the prostate in specific, and we can localize at least a suspicious lesion. And then the urologist can specifically target that region
Nice. Okay.
for higher yield.
Right. Oh, I like that,
For a
higher
more
yield.
specific result.
And Claudia, this kind of comes to your questioning too now. So we talked at the beginning of the program that, okay, you have cancer. That is something that now the biopsies have been taken, now that there is a diagnosis. What are the most common cancers that you find you need to navigate people through? And again, going back to, there's some that are cut and dry, and there's some that are not. So just in your practice, in your years of doing this, which cancers are the ones that are like, oh, there are a lot of different options. I don't know how to go through this.
Right.
What type of cancers are those usually?
Well, breast is still a big one.
Okay.
Because their treatment is long sometimes. Okay, and again, there's a lot of different phases and issues that come up. There are the GYN cancers, so ovarian cancers, uterine cancers. all of those. They also sometimes they have to have radiation, and some of them have to have chemotherapy, surgery. So there's a lot of steps, to try and get that person to be cured.
Right.
Okay. Colon cancer, is another one and all of these cancers, you have to also think about what it does to the body image. Okay.
Right.
So sometimes with colon cancer, if the patient needs a colostomy, that's.
And explain what a colostomy is for those that don't know.
Yes, that's just a pouch that comes out, through the stomach, okay, where you collect the stool, okay, and sometimes that's temporary, and sometimes it can be permanent, okay, but it is something that the patient has to deal with now,
Right.
and its body image. There's a lot of things that come along with it. Maybe they have to change their diet. There's a lot of education that goes along with that. Okay, and then not only that, but sometimes they all still need chemotherapy or radiation, or those are probably some of the most difficult head and neck cancers as well.
Oh yes.
Okay.
Right.
Again, a lot of these cancers where we're dealing with body image issues, and there's a change in their status, or maybe the patient can no longer work. So there's financial
Exactly.
issues that we
and
have
that
to
in
talk
and of
about.
itself needs its own navigator.
Right.
There are
Absolutely.
so many questions on that. Dr.
A
Pietro,
whole,
yes.
a whole program for that.
Oh yeah, or 50.
Yes.
And that's one of those, because I know this is a medical program, and a lot of doctors, and I'm glad that you say that, a lot of doctors like, that let me focus on the medical stuff.
Absolutely.
But that's part of a true reality, and where a navigator would come in, because there are times like, well, is this less expensive and is this not expensive? And it kind of goes through that. I'd like to talk a little bit about staging. So when you hear the words you have cancer, and sometimes you have the stage and sometimes you don't. And you can kind of bounce back and forth, radiologist, doctor. So when you're looking at breast cancer, and you had a great point, sometimes, if it's very localized, it's stage 1. But let's talk about, there are so many different cancers, and they're all staged differently. Like a stage 2 breast cancer is very different than a stage 2 like pancreatic cancer or lung cancer, et cetera. How is that done? And I'm kind of looking at you, Dr. Pietro, I'm going to have you start, but as the person who kind of figures out the staging and imaging, how do you find out what the stages are, and what do they mean?
And so what they mean, that's a beautiful question, because I quiz residents on this all the time.
Oh, look at you. Good job.
So staging is basically the evaluation that goes when a person gets diagnosed with cancer, to determine how far extensive that cancer has invaded the body, or how much it is spread in the body, because it relates directly with prognosis of the patient. And although different sites bear different staging criteria, what we try to accomplish with the staging is that there is a certain survivability associated with each stage, that one can say for stage 1 breast cancer, we are going to see very similar survival patterns as with a stage 1 colon cancer. But the staging evaluation may be a little bit different, okay?
Right.
Because of the different organ site, the different parameters that go into the staging criteria. Now, the staging itself is basically a joint effort that is nationwide, now international, as a matter of fact. So a stage 1 or stage 2 breast cancer here in the U.S., here in El Paso, is defined the same way, say, in Mexico or
so it was
in
not
Europe.
before? It was staged differently before?
So years before, decades before, there were more. It was more regional, more national.
Interesting.
Okay. Good 40 years ago, the International Commission on Cancer, got together and, along with the American Joint Commission on Cancer, devised a strategy to basically have a more uniform way of staging cancers that has meaning, and the meaning is basically which are salvageable cancers and which are cancers that are too far spread for cure. So it relates to the prognosis that is associated with the disease, which then basically translates to the treatment strategy that we're going to
Exactly,
follow. Okay,
right.
I mean,
And that's where you come back in too.
that's where
Navigation.
and that's where Dr. Loya comes in also. Okay, because as an oncologist, I get the pathology report saying that this person has a tumor in the lung that has a cancer, adenocarcinoma. And I say, well, I can see the chest x-ray with a tumor that is this size, but has it already spread into the lymph nodes in the mid-chest
Right.
area? Has
Right.
it gone beyond that? And so that's where I recruit the help from my buddy here to get me CT scans, maybe even something as modern nowadays as a PET scan. Okay. And I mean, all those technologies are available here in El Paso. Okay, so people can get basically what is the standard of care nationwide here in El Paso in that regard.
Exactly. And Dr. Laura, I'm going to bring that to you too. So we're talking about the different scans. You've got the MRIs, got the PET scans. We talked already about mammography, a little bit about ultrasounds, but in general, and I know I'd like to get to lung cancer screening too, because that's, for me, that's relatively new. But in your world of all of these imagings, and again, as a navigator, what do people know to ask for? Or do they simply come to you and say, just figure out what you need to do? Do they know what test to ask for? Or is that just something that's automatic when they come see you?
So the most widespread use would be CT,
Okay.
and then combine that with PET CT. And one of the most important jobs that we have as radiologists is to describe what we see and describe it well, so that
Dr. Prieto knows what to do.
Exactly, so that
Okay.
he knows what staging the patient is on. For example, he was talking about a pancreatic cancer patient, and is it treatable? Well, my job is to tell him, is the tumor confined to the pancreas only, or is the tumor already touching the vessels nearby? That's very important to him. That's one of the most important jobs I have. That's
Right.
staging. And then, yes, he would order for a broader staging, a CT chest, to see if the cancer has gone to the lungs, or I can see down in the pelvis if the cancer has gone there, or to the liver, examples like that.
That's a lot of pressure. I mean, really. I mean, if you're looking, it's like, I have a lymph node question, because I feel like with so many cancers, lymph nodes are taken and either biopsied or somehow to see if there's some kind of a diagnosis of spreading. And that's something that's always been interesting to me. So if you have some kind of a breast cancer diagnosis, for example, there's a sentinel node, am I saying that right? The sentinel node,
sentinel.
and then other lymph nodes. Explain how and why lymph nodes are also taken with certain types of cancers to check them out.
Yes, of course. So, like for your example, you have a breast cancer, a breast mass. The path in which the cancer is going to spread is through our lymphatic system, and the closest two chains are the axilla and a chain we have here in the mid-chest, internal mammary chain.
A chain. So there's a chain
There's
of lymph
chains
nodes?
of lymph nodes, correct.
Okay.
And I bring that up because that helps explain the sentinel
No,
lymph
it's a
node.
nice way to graphically look at it.
So,
Okay.
so the first lymph node in that chain closest to the tumor is our sentinel lymph node.
Okay.
So the way a surgeon would be able to localize it and remove that first one to see if that one is involved, is we inject radio tracer, at least in the breast, and the radio tracer goes to that first lymph node, and the surgeon is able to use a radar, localize where the tracer is, and remove it, and he's able to see if that lymph node is involved, if it has cancer.
Here's my curiosity too. When you say the lymph node is or isn't involved, and again, pardon my ignorance on this, is there a mass in that lymph node? How can you say, is there a chemical reaction in there? Is it, you send a fluid in there and it turns bright, whatever? How do you know if a lymph node is involved?
Very important. Two most important things for lymph nodes are size and morphology, the form of it.
The form of it.
If a lymph node is less than 1 centimeter in short axis in its width, we assume it's not involved, unless the morphology has changed.
Okay.
A lymph node has fat in the middle, fatty hilum, like a normal lymph node like you and me have, has fat in the middle, fatty hilum. the lymph node that may have cancer loses that fatty hilum, becomes round, and it becomes like dark, no
Interesting.
longer fat in the middle. And if we see that either bigger than 1 centimeter,
Okay.
or if it lost its normal morphology, then we report to Dr. Prieto, hey, we're concerned this is suspicious of cancer involvement in this lymph node.
Okay, very nicely explained, actually. And in general, Dr. Prieto, I'm going to ask this of you, how many lymph nodes are usually taken? So when you're talking about this chain, and I know there's the underarm lymph nodes, there's one in the middle of the chest, there's groin lymph nodes. How many lymph nodes are usually taken? Does that depend on what the original staging may have been, or does that also help stage the cancer?
That helps stage the cancer. As a matter of fact, that's the pathologic staging procedures that we carry out. Let's take, for instance, the breast again, okay? And so we have the tumor. The surgeon goes in to remove that tumor, injects that radiotracer dye, follows the course of how that tracer moves through the lymphatic vessels into the lymphatic chain, sees basically with a radiotracer that 1 or 2 or 3 of those lymph nodes take that dye or that material. He extracts those. He actually plucks those lymph nodes out, sends them for pathology analysis, and it's a pathologist who tells us if that lymph node or those lymph nodes are involved by the cancer cells.
Okay.
Okay, and so so we have the appearance maybe before surgery that there's already abnormal features to those lymph nodes that we already suspect. We can say, yeah, very likely those are affected, but we need, in most cases, the pathologist to tell us that yes, in fact, they are affected. At that point, we have pathologic confirmation that that lymph node is affected, and then we can basically tell the patient with certainty that their breast tumor has this lymph node or these many lymph nodes affected. The surgeon, when they do surgery, they explore basically the chain or the region to feel for lymph nodes that may be enlarged.
Right.
Okay, it's usually a physical exam. And if they feel bulkiness in those lymph nodes or the texture of the lymph node is indurated, then they basically say these are suspicious lymph nodes, we take them out.
Right.
Depending on the body part also, okay? I mean, there are what we call regional lymph nodes that come all kind of in a cluster together, okay?
The chain, so to speak.
The chain,
right?
exactly right.
Yeah.
You just strip that out. In a different organ, say for instance the colon is divided into sections, and when they remove the section of colon that has the tumor in question,
Right.
they remove that whole wedge that comes with it, and all the lymph nodes that come in that tissue become the candidate lymph nodes.
So I should have asked this first. So I'm going to back myself up for a little bit. So to explain what the lymphatic system does for us, and when we take all these lymph nodes out, is there an issue with that? Are there any problems with that? So on this note, because lymph nodes are so involved, what does the lymphatic system do? I mean, again, they're everywhere. And
everywhere.
I always think of draining. They're in charge of draining.
Absolutely.
But explain it the way you'd like to explain it.
Yes, and so the lymphatic system in the body is basically primarily responsible for maintaining homeostasis from insults to the body. So it's an immune system basically, and it's there to capture anything that is deranged in terms of how the body is functioning.
Deranged. I like your
Deranged,
wording.
yes.
Yes, it's an insult and it's deranging. No, but it makes sense because again, we talk about it all the time, but we don't talk about the function of them.
Absolutely.
You know.
And so those are the lymphatic vessels along with the lymph nodes, okay, take care of draining all sorts of fluids and rebalancing fluids in the body as well. But in that process also, it recognizes what is foreign, what does not belong there, be it an infection, okay, or a cancer, or maybe even perhaps becoming dysfunctional immune system, okay, whereby the immune system starts attacking the body for whatever reason, and you start having these lymphatic areas getting inflamed, enlarged, okay. In most normal cases, the lymphatic system is there to guard what is happening in the body altogether.
Right.
When a cancer shows up, obviously the immune system recognizes that as something foreign, something very offensive, and starts to try and mount a reaction against it. Initially, it may be right at the local level where the tumor is arising, okay, but sometimes it's not capable of targeting things right then and there, and so the cancer cells start migrating through the channels into the chains, into a lymph node to populate that lymph node, nest there, whereby...
So it's all communication.
It's all communication.
It's all communication in the body.
And from an immune perspective, you say, well, you remove those lymph nodes, what's going to happen? Well, the body has amazing capabilities of regenerating and regrouping, basically. From an immune perspective, there's not much danger in that regard. Whatever you remove, chances are that in time will be reconstituted again. But in some cases, especially when extensive surgeries are done, say in the groin areas or in the axilla, basically where appendages meet the core of the body, then you can have problems that result thereafter, especially when there's surgery and radiation therapy involved, whereby the lymphatic drainage reconstitution is not as effective or efficient. And then you end up with problems of swelling of that limb, okay? Condition we call lymphedema. That is very, very known, especially in breast cancer patients. And so that's where navigation comes into play also.
That's a perfect transition to Claudia. So I was thinking too, as you were speaking, because treatment happens in so many stages. Again, there's the direct one. Perhaps sometimes you can do surgery, everything's gone, you're done. But now we're looking too of the residual effects of certain types of treatment. And so, Claudia, I would love for you to brag about what you do, brag about the Hospitals of Providence, brag about this program. When you start with a patient and their family, and they are now going through different types of treatment, let's just say, case study, let's pretend that somebody has had surgery. They are going through chemotherapy right now, then radiation is on the way, but there are things that come up. And even though they have, figured out what it is, what course of treatment there is now, are they still able to call you during the course of their treatment and say, you know what, this is going on, I'm not sure if this is okay, what do I do? How do I deal with it? Who do I call? Talk a little bit about that and navigating people through different stages of their treatments.
Sure. Absolutely. So, initially we do all the teaching, their chemotherapy, but also we're teaching them about, what to look out for, so toxicities of the chemotherapy, what to do about them, and then as well as like lymphedema. Okay, so these are complications that can happen. Not immediately. Sometimes it's something that they need to be on the lookout for the rest of their lives, essentially. But we reassure them and we tell them that the first sign that you see this, you need to let me know. You need to let your doctor know, and then because there are things that you can do about it. Your doctor will refer you to the therapist. There's occupational therapists that can help with the lymphedema treatments. Other things like if you're having nausea, vomiting, because of your chemotherapy, what is it that we're going to do? We're going to help you with nutrition evaluations. That's also important. These are all considered rehabilitative and supportive services that we are able to provide. Okay? And that we are able to guide them and to say, you know what, you're having this issue, there's something we can do about it. You don't have to live like this. There is something that we can help you with.
And as part of that education, making sure that they do reach out to you, or do you all proactively reach out to the patients? Like, is there a scheduling?
Yes. Well, we do both, because there are some patients that are, very much, they call us for everything, and that's great.
And then there are others
that no, and you have to. So typically, I try to follow them closely after they've had their chemotherapy, especially, their chemotherapy. I'll call them, see how did they tolerate it. If they're coming to our clinic, okay, because we do infusions at the Hospitals of Providence for chemotherapy. So I try to meet with them while they're there, and just to make sure make sure they're doing okay. And then after that, if they have completed their treatment, sometimes they come back to our clinic for port cath flushes. These are just lines that are put in place, and that's where they're receiving their chemotherapy. And sometimes those lines are not removed after they've completed their treatment. They're left in place because now they're in cancer surveillance, and they may stay in that place, for a few years, sometimes 2-3 years.
Sometimes. Okay.
It depends on the oncologist. It depends on what kind of cancer they've had.
Okay.
If it's a cancer that maybe there's a chance that it might come back, and they might need more treatment. So we watch them, and that's where we continue the surveillance part.
Gotcha.
That's where we explain to the patient that, yes, you have this, you need to have it cleaned out, you need to have it flushed periodically, because there are some patients that don't know, and then they don't come back, and then the cancer
Right.
comes
Could
back,
be an
and now we want to
infection,
use
could
it,
be
and
right.
and we can't use that anymore.
Okay.
Okay, so there's teaching that is involved about survivorship.
Right.
What happens after you're completed your treatments. So we try to keep in touch with our patients, calling them, monitoring them. And of course, always telling them, if you have any questions, please, call us, reach out to us. And like I said, there are some patients that they're fine. They don't really need us, but then
How
there are
nice to
others
know that there
do.
is someone that you can call. And to me, I'd imagine that the relationship right there is priceless. When you have someone that, well, I know Claudia, I've talked to her a couple of times, and would she mind if I called her? I think that in and of itself, just the idea, whether you need it or not, just the idea that you're there is priceless. And I know when we talked about the beginning of the show, we're talking about the beginning of, okay, you have cancer, now what? But I love hearing that there is follow through. And even if a treatment lasts 6 months to a year, that you're still around 2 or 3 years from now. If something looks a little bit funny, if however that goes.
One of the things that with the navigators, okay, and Claudia is one in the team of navigators that are available there, but many times the patient is reluctant to call the doctor's clinic, or they call and they say, well, they never give you the message, or
They're
it took
intimidated.
you.
Yeah, absolutely. That's what I'm saying, the
Intimidation,
relationship.
exactly
Yeah,
right.
yeah.
And there's basically no barrier in that regard with the navigators. They feel comfortable. They feel that it's a buddy who's really there to hold them, to hold their back, basically. And the beauty here is basically that the patient, very easy to communicate with them, but then the navigators are very easy to communicate with us, the doctors, and to let us know this patient is calling and having this problem, and this is what I told them, but I think you need to see them.
So you are bringing up a great point, and I have that as one of my questions too. So there are the patient and the doctor. So if the patient comes to Claudia, and let's say it's somebody that's really shy, really intimidated in general, so what is that relationship there with the patient navigators and with the doctors in general? How does that work with the oncologists, with the surgeons, with radiologists, et cetera? Are you the first line that comes to the doctors at that point?
Sometimes, yes.
In the rah-rah of the patient, so to speak, representing the patient?
Sometimes we are, because
Okay.
again, some patients, they live with something because they think that, well, I guess this is normal, or they don't want to call the doctor to bother them because they're really busy, so that's the reason.
Why would you want to talk to me,
Right.
little old me?
That's
this
right.
is super important that
It
we
is.
talk about this,
It
because
is.
I think I know people who
Yeah.
have just thought, well, it's been 4 months since I've had this and I don't know. And then, then honestly, literally, sometimes it's too late.
Yes.
So talk a little bit about that you are the conduit, so to speak. You are the in between, the vehicle, nice word, between the patient and the doctors.
Right. So again, reach out to the physician. This is what's going on with the patient. And sometimes they're like, okay, we need to order this or let them know this. And so we relay messages back and forth in between, and not just to the oncologist, sometimes the clinics. Sometimes the patient really needs another biopsy.
Right.
So we are there to schedule those patients and call the scheduling department. And sometimes there's issues with their insurance company.
Right.
And so there's been times that I've called insurance companies, to get authorizations for certain, procedures that need to happen ASAP. And sometimes, it's no one's fault, but sometimes, like scheduling departments or other places, they don't understand that this is something that's very urgent,
Right.
So, and the patients, they don't know to say that, they're like, okay, well, they gave me the appointment until a month from now, I guess, this is it. But there's other things that we can do. Can we find them? Can they be scheduled somewhere else? So there are things that we are able to do as navigators because we have a lot of resources that are at our disposal. I mean, we can make phone calls. I mean, that's our job. And sometimes patients sometimes are at work, and they can't be making all these calls. So again, I tell them, please, I can help you with certain things. I can make those calls for you so that you don't have to, take time off from work because, it's taking an hour to get through an insurance
Right.
company or Medicare, and so we're able to help with those issues.
Very
Transportation is another big one,
You brought that up earlier, and that's a great point too. Years ago, I worked with the American Cancer Society. I was there for 12 years, and one of the big programs that I really loved was Road to Recovery, and we had volunteers that used to take cancer patients back and forth. And again, if you're doing radiation, it's every day for weeks, months on end sometimes. On that note, and let's talk a little bit. We were talking about insurance, but just let's talk a little bit about, and I know it's hard on a medical show, when it costs too much to do A, B, and C. Where does the navigator come in on finding resources then for patients? And I know it's a hard question and it's different, but that is part of the reality again. Dr. Prieto, you're kind of nodding too, so feel free to chime in on that.
That's where she gets a weapon and goes to one of the banks downtown and says, I need...
This is where with the class clown, when you said that earlier. Right. No kidding.
Yes. So there are a lot of foundations that are available to our patients. Okay. It could be a different, sometimes it's very cancer site specific. So there are, like, for instance, the Lymphoma and Leukemia Association Society. There's lots out there, but again, you have to be able to know and to look for it, and now we have internet and we can do all of this, but there are some patients that they're not well versed
Right, exactly.
with this,
Exactly,
they don't have
right.
the time, they don't have the energy, okay, because a lot of them, they just don't feel good. The
Right.
treatment's not making them feel, the disease isn't making them feel well.
And it's
So-
overwhelming.
And it is
Again,
overwhelming.
To say that word over and over again,
Yes.
but it just is.
It is. It is. So we are able to. We also have a social worker as part of our navigations team, and so she's also a resource to us. She understands when we don't know what does Medicare, Medicaid do. She's there to help with that. So we're very lucky in that sense that we're able to move, we're able to find resources. Sometimes it's just locally, there are some foundations here, statewide, and all across the nation, there is. So we are able to help some patients with that. And sometimes it takes time, and sometimes we're not very successful right away because they run out of funds, but we're persistent, so we check again.
Thank goodness.
And
Right.
and
Right.
so but it is tough. It's really
I can
tough out there
imagine.
for these
So,
patients.
one of the things that I have to say here in El Paso is I think that there's a lot of involvement with the, I think, local government agencies, okay?
We are lucky that way.
We are, as a matter of
agree.
fact, okay?
I agree.
There are programs in the city, in the county of El Paso, that extend services for people who are either uninsured or underinsured. And as long as there are residents within the county, okay, those resources are available, okay? And it's all furnished basically through local, city, county, state, and some federal grants as well. And so for patients who get diagnosed with cancer, who are uninsured or underinsured, I mean, the world falls not just by the disease itself, but then how am I gonna finance this? Or how am I gonna
Exactly.
get the care? I don't have insurance, I don't have money, I don't have a wealthy uncle, okay?
Yeah, and sometimes you don't know. Again, you don't know what you don't know.
Correct.
That phrase is so specific in this situation.
Correct.
And that's where Claudia and her team, the patient navigating team, comes in to try to figure out what it is that this particular patient needs.
Absolutely. And I think as navigators, and especially with the social worker involved, there's a network within the city that they know that if we cannot provide the care here because you're not insured, okay, we can always refer them to this other place, okay, where they can get these resources going. I mean, I don't know if I can make mention of Texas Tech, UMC, okay. I
Make
mean,
mention of anything
Okay,
that people
so-
might be able to find helpful.
I mean,
Absolutely.
UMC basically being the county hospital, and Texas Tech basically providing the county residents the support services. Both of them offer programs for those who are underinsured or uninsured, so that's where those patients get referred to continue their cancer journey.
Right. Agreed.
And the social workers and navigators in those facilities take over where our navigators basically hand off, okay? They don't drop off, they just hand off so that someone else can take over that job.
Right. And I'm going to bring this back to Dr. Loya as well, because again, when we're looking through treatment, and there has to be, I'm assuming, re-imaging along the way when people are going through treatment. So we're now looking at someone who is undergoing chemotherapy and now has the tumor shrunk enough for surgery. I've heard that so many different times. So I'd like for you to pick it up on that. So we talked a lot about diagnosing in the very beginning, and now take it from the radiologist who is looking at something. You've got your base, I guess, once the tumor was a certain size, and now we're 3 months in chemotherapy and there is more imaging. Talk a little bit about that, because this is going so fast and we only have like 3 minutes left, but I want to talk quickly about that, of how you re-image and then re-diagnose during treatment.
Very, very important, and for the community to know we have people like Claudia, because follow-up is one of the most important things. Sometimes we see people that get lost to follow-up, and maybe the tumor is now, bigger on our follow-up study.
Right.
But yeah, as it concerns to us, it's very important, again, to describe everything we see. Not only has the tumor shrunken or maybe grown, but the characteristics of it. Maybe it's the same size, but maybe now it's dead tissue. Maybe it's not viable tumor anymore.
Nice. Yeah, that would be the hope, right?
Correct.
Yeah.
So, we do see a lot of follow-ups.
Okay.
Sometimes 3 months, sometimes 6 months. But very important to be, as a team, on the same page. On the same page, to have the priors like we had before. So yes, very important for the community to know. Once someone's diagnosed with cancer, it means the world is falling. But very important to have a team like this, because they're not alone, and the follow-up is gonna be very, very important.
Exactly.
And a team like this is gonna help with that a lot.
Well, I love this team that everybody is together with here. I want to say thank you so much again for being here. Dr. Loya, again, radiologist, the imaging guy, Dr. Prieto, who's the oncologist, and then Claudia Sanchez, who is the patient navigator who helps along with everything. If you received your, actually, I'm getting the screening. We have time for that, but if you can get screened for whatever it is. It makes such a difference when you're diagnosed early, staging, et cetera. If you just tuned in, there are several places that you can watch this program once again. There is pbselpaso.org. There's also EPCMS. Just think of the acronym, the El Paso County Medical Society. They have this program on their website. And then also YouTube, good old-fashioned YouTube that has been around for a while now. Just youtube.com. And if you just look up the words The El Paso Physician, you can find this program and several other programs as well. So that's one of those places that I go to all the time to find research and figure out what's going on. But a big thank you to the Hospitals of Providence for doing the show, for underwriting the show, and as always, the El Paso County Medical Society for, again, doing the show for over 26 years. I'm Catherine Berg, and this has been the El Paso Physician.